Good morning, everyone. Today, we'll be exploring pemphigus, a rare but serious group of autoimmune blistering disorders that primarily affect the skin and mucous membranes. Pemphigus is characterized by the formation of intraepithelial blisters due to autoantibodies targeting desmosomal proteins, which are seen on cell-to-cell adhesions of the skin. So pemphigus is an autoimmune blistering disease of skin and mucous membranes, which is characterized by intraepithelial blister formation. For a brief history, pemphigus is derived from the Greek word pemphix, which means bubble or blister. This is a characteristic feature of clinical cases of pemphigus. Coming to the etiology, or the cause and how the disease progresses, pemphigus is caused by autoantibodies which are directed against components of desmosomes. Namely, the component is termed as desmoglein. These desmosomes are seen as part of the intercellular junctions. Now, when these desmosomes are attacked, it causes disruption of the intercellular junction, and this results in loss of cell-to-cell adhesion, a condition which is termed as acantholysis. So when the cell-to-cell adhesion is lost, it results in a blister, which is seen at the level above the basement membrane, and that is termed as an intraepithelial blister. For a molecular aspect of this pathogenesis, we can see that this is a schematic diagram demonstrating the targeted structures in pemphigus, where we have the desmoglein 3 as a component of the desmosome, which is seen attaching cells to cells. It is seen above the basement membrane. And hence, the point of attack is usually sparing the basal layer of cells and involves cells which are seen above the basement membrane. The main component attacked in pemphigus is desmoglein 3, while we also have desmoglein 1, which is attacked in certain variants of pemphigus. There are several forms of pemphigus, but the most common and clinically significant types include pemphigus vulgaris and pemphigus foliaceus. Pemphigus vulgaris, the term denotes that this is a very common variant, and the other variants are less commonly seen. Pemphigus vulgaris often begins with painful oral lesions before spreading to the skin. They are said to be the first to come and the last to go. Understanding pemphigus is vital due to its potentially life-threatening nature if it is left untreated. But with advances in immunotherapy, there has been significant improvement in the diagnosis and treatment, especially with the advent of corticosteroids and immunosuppressive therapies. Looking at the clinical features of pemphigus, this disease usually develops or manifests in the 4th to 6th decades of life. There is an almost equal sex predilection, although some reports do give a slightly higher female predilection. There is a definite ethnic and genetic predisposition which needs to be noted, and it affects skin and or mucosa of the eyes, of the oral cavity, and other mucous membranes in the body. 50% or more of the cases usually start in the mouth. So the first lesions may develop as vesicles in the oral cavity, and they are termed as the first to show and the last to go. These present as painful ulcers, which are usually preceded by small vesicles and bullae, which rupture and leave behind ulcers. They tend to be persistent. The disease can be progressive, and an important clinical sign which is elicited for arriving at a diagnosis is termed as Nikolsky's sign. These are some of the clinical images of pemphigus lesions. We can see that initially on the skin, the lesions are seen as vesicles and larger ones are termed as bullae. After a brief period, they tend to rupture and become flaccid. Occasionally, they can become infected or there will be loss of surface epidermis protection, causing secondary infections. And crusting lesions can be seen as can be noted in this clinical picture of extensive lesions over the torso of this patient. Oral manifestations include similar vesiculobullous lesions. Usually, the vesicles are ruptured by the time the patient arrives at the or gets a consultation with the doctor. So we tend to see more of ulcerative and erosive lesions as well as crusting of the lip, crusting and hemorrhagic crusts which are seen on the lips. Another manifestation which is of importance is seen in the gingiva. The gingiva appears to be peeling away. That's termed as desquamative gingivitis and is seen as erosive or reddish areas which affect the marginal and sometimes attached gingiva also. A common sign which is elicited is the Nikolsky sign, as was mentioned earlier. Nikolsky sign is when lateral pressure applied to intact skin or mucosa results in peeling away of the skin. This is termed as a positive Nikolsky sign and is a clinical diagnostic test or a clinical chairside test that is used to identify pemphigus from other vesiculobullous lesions. The oral lesions which we just saw can be described as superficial, ragged erosions and deeper ulcerations, which are distributed widely over the oral mucosa. They tend to be preceded by a vesicle or a larger bullae and can come on any oral mucosal location, namely the palate, labial mucosa, buccal mucosa, ventral tongue. Gingiva is also involved. When the gingiva is involved alone, the presentation is termed as desquamative gingivitis. Most of oral lesions can precede the cutaneous lesions. Now, coming to the Nikolsky sign, gentle traction or lateral pressure on clinically unaffected mucosa or skin may produce stripping or peeling off of the epithelium. This is a characteristic feature of pemphigus, which is negative in bullous pemphigoid, which is another vesiculobullous lesion, which can be confused clinically for the same. This Nikolsky sign is caused by prevesicular edema, which disrupts the dermal-epidermal junction. The clinical photos, show the method in which this test can be done. Another clinical chairside test that can be elicited is referred to as the Asbo-Hansen sign. The Asbo-Hansen sign is extension of a blister to adjacent unblistered skin when pressure is placed on top of the bulla. So vertical pressure placed on the bulla will result in lateral extension of the blister. This is the Asbo-Hansen sign. Coming to the next variant, which is called as Pemphigus vegetans. This is an uncommon variant of Pemphigus vulgaris, which presents with two clinical subtypes, the Newman and the Halopio type. These present as verrucous or vegetating plaques with pustules. The lesions are typically located in the groin, axilla, and the flexural surfaces of the arms and the feet. In the oral mucosa, similar vesiculobullous or vegetating plaques can be seen. Additionally, a characteristic feature involving the tongue is an appearance which is called as the cerebriform tongue, where the tongue appears to have multiple fissures and cracks resembling the surface of the cerebrum. So the term is cerebriform tongue. It's also called as Premalata sign. It's an eponym based on the person who first described this sign. The skin lesions which are seen over the groin and the axilla look like thick, hard plaques which are non-scrapable and usually can have pigmentation. Another variant of pemphigus is termed as paraneoplastic pemphigus. This is a form of pemphigus vulgaris that occurs in association with a pre-existing occult or confirmed malignancy. In patients with non-Hodgkin's lymphoma, chronic lymphocytic leukemia, and Castleman's disease, can develop a type of pemphigus which is seen in association with these kinds of neoplastic disorders. Here, the pathogenesis mechanism is that antibodies which are produced to the tumor cross-react with antigens associated with the desmosomal complex and the basement membrane zone, resulting in vesiculobulous lesions similar to pemphigus. Coming to the diagnosis can be taken in several phases. The first part of the diagnostic examination would be clinical and the chair-side tests. The clinical chair-side tests include the Nikolsky sign and the Asbo-Hansen sign. Further, an exfoliative cytology from a freshly ruptured intact vesicle will reveal Zank cells, and the test is called as a Zank test. Second diagnostic procedure would be a biopsy of the perilesional tissue. It is important that a freshly ruptured vesicle and the perilesional area is taken for the biopsy. Otherwise, the biopsy can be non-specific and will not be providing a correct diagnosis. The confirmatory diagnosis for all vesiculobulous lesions involves the direct immunofluorescence or DIF and the indirect immunofluorescence or the IIF. Direct immunofluorescence is done on fresh lesional tissue which has to be fixed or transported in Michel solution. It is important that correct transportation is done. You should not do a formalin fixation because the antibody reactivity will be lost and there will be no immunofluorescence findings on formalin fixed tissue. So fresh lesional tissue has to be transported in Michel solution, and this will help to demonstrate the autoantibody which is already attached to the tissue. In indirect immunofluorescence, examination of the patient's serum is done to identify circulating antibody. Histopathology will show intraepithelial cleft formation, which is termed as a suprabasal cleft. The basal layer remains attached to the basement membrane, resulting in a row of tombstone appearance. Additionally, acantholytic cells will be seen within the vesicular space, and these clustered keratinocytes are called as Zank cells. This is the procedure for direct and indirect immunofluorescence. So if you're suspecting a vesiculobulous lesion in a patient, for the biopsy, you should prepare for 2 samples. One will go into formalin for routine H&E diagnostics, and the second one should be transported to Michel solution, immediately put in Michel solution, and this should be transported for immunofluorescence. So to avoid confusion, at the same time, both these samples can be taken and correctly fixed as separately, one in formalin and the other one in Michel solution. Now, the one which goes for Michel solution will undergo direct immunofluorescence, where fluorescin conjugated anti-human IG antibodies will be applied on the patient's tissue specimen. The excess is washed off and it is viewed under the fluorescent microscope. Similarly, in indirect immunofluorescence, the patient's serum is taken and it is bound with monkey esophagus, a homologous type of tissue, and that will also take up positive stain in cases of pemphigus. The pattern that is seen on biopsy direct immunofluorescence of skin or mucosa is termed as a fishnet or chicken wire pattern. Here we see deposition of immunoglobulin in the intercellular spaces between the epithelial cells. Now, for indirect immunofluorescence, examination of the patient's serum is done to identify circulating antibodies, as was shown in the previous slides. Treatment of pemphigus. It is important that pemphigus be diagnosed and treated correctly, as untreated cases can have a morbid outcome. Treatment involves controlled with immunosuppressives, which at first level steroids, both IV, intravenous steroids, as well as immunosuppressives, namely azathioprine and cyclophosphamide. There can be a high mortality if pemphigus is left untreated. This can be caused by excessive fluid loss, infections caused by rupture of extensive vesiculobullous lesions and their rupture. This can result in dehydration, electrolyte imbalance, malnutrition, and severe infections. Thank you.